Now, in your packets that you've been given earlier today, there would be a save the date for the World Parkinson Congress. It should be sometime in mid-September of next year. How many of you guys have heard about the World Parkinson Congress? So not nearly as many as I think that they should. So 2004, okay, a very prominent movement disorder neurologist, actually one of the godfathers of movement disorder neurology, Dr. Stanley Fahn, who actually is a Sacramentan. And he helped to build up the movement disorder program at Columbia Medical Center in New York, recently retired. He thought back in 2004 that it was somewhat interesting that physicians and scientists go attend their conferences and discuss information at a very high level, and patients go to their support groups, and there hardly is much connectivity between the two. So he thought, why not actually have a conference for everybody? Patients, with physicians, with scientists, with caregivers, sitting side by side, learning from the experts, helping to create a greater sense of community, a better understanding of Parkinson's disease. So the World Parkinson Congress, which is basically hosted by the World Parkinson Coalition, based out of New York City, has a conference like this that lasts about 4 days every 3 years. The first one was held in 2006 in Washington, D.C. I had a pleasure of actually presenting a poster at that conference. 3 years later, it was in Glasgow. 3 years after that, Montreal. And now next year, it's actually coming fairly close to home, Portland, Oregon. Okay, the Oregon Health Sciences University is helping to host it, but this is an opportunity. It isn't going to come back to the West Coast for another 15 to 20 years because it's probably going to go to either, they're thinking right now it might be Kuala Lumpur or Hong Kong, and I'm assuming that most of us are probably not going to be able to make it out there. So that's why we put that in there. Now, that being said and done, they want to keep the theme of that World Parkinson Congress exercise and the importance of exercise and how we should all be exercising, not just for patients, but for caregivers. Because we find all too often that caregivers who don't help their patients, their loved one exercise, who don't participate with their loved one, then unfortunately the patient also probably doesn't follow through either. So the Brian Grant Foundation, okay, Brian Grant is a name that you all should know because he actually was a rookie basketball player with the Sacramento Kings in the mid-1990s. Was here with the Kings for about 2 or 3 years, after which he went to the Miami Heat and then unfortunately, went to the Suns and the Trailblazers and the Lakers and had a 12-year NBA career, retiring in 2006 or so, 2008, something like that. A year later, at a very young age, he was diagnosed with Parkinson's disease. But he wanted to use his celebrity status, the fact that he is an athlete, and use it towards the benefit of reaching out to Parkinson patients. So he forged the Brian Grant Foundation. So the Brian Grant Foundation has actually been tasked with putting together the exercise sort of content for the World Parkinson Congress. And it doesn't start at the Congress. It actually starts months before. There's going to be a hard launch of this whole Power Through Portland project. So I'm going to have Brian actually talk about it himself.
This is where it all begins. Right here in my own hands. I know the road I must travel, but I'm grateful to have a choice. My life will be what I want it to be, not what Parkinson's or anything else tries to make it. I fight knowing I can win. I know I don't stand alone. I will arrive where I wish to be. It's time to power through. My mind is being challenged. My heart is being tested. I've never backed down from fear. So I have no excuse. I, Brian Grant, commit to power through from Montreal to Portland, Oregon. I dedicate this commitment to my son, Jaden Grant. I believe that I'm capable, that I'm fearless, and I believe I will power through. This is my commitment. Where's yours?
So the Power Through project is going to launch in January of next year. Every month on the website, they're going to feature a specific Parkinson exercise program, whether it be dance therapy, boxing, LSVT Big, the power technique done by Becky Farley. And between each of those, they're also going to talk about exercise principles. The website will have content on what muscles are activated in those principles, why this is problematic in Parkinson patient experiences and blogs talking about their experiences with these type of things. And this is going to be internationally launched. The World Parkinson Coalition has a membership of 2 million people. Okay, it's the largest coalition of Parkinsons in the world because it's the World Parkinson Congress. So that being said and done, that's why we're promoting it here. We're hopeful that a lot of you guys may join us up in Portland for that conference. But before you actually get there, that you commit to doing exercise. Every time you exercise, you're supposed to log in. So you have to register for this. It is $25, which sounds like a lot. But that money isn't going to the World Parkinson Congress. It actually is going to help to ensure that people who cannot fly out there, who can't register for the actual event, can now register. So people from poor rural communities. It will not go to the actual content itself. Everyone who's involved in content making is doing so voluntarily. And we're talking hundreds of hours. Myself, Erin, and Christine are all heavily involved. So again, $25 to register gives you a lot of information, and hopefully it spurs a movement when it comes to exercise in Parkinson's disease. So I have another video I want to show about how to be committed. And on the PANC table outside in the front, we have commitment cards if you guys are interested.
It's time to power through. Making a commitment is simple. Fill out your name, your city, and your country. We want to connect the world. Dedicate your commitment to someone you love and who will hold you accountable. Be creative, have fun with it, and share it with the Power Through community.
I, Natasha Roos, Lizzie Weber,
Jeff Lasley,
Stephen Fine,
Linda Benson of Portland, Oregon.
Commit to participate in the Power Through project.
From Montreal to Portland.
Side of the 2016 World Parkinson's Congress.
I make this commitment to Suvi Murka, my daughter.
To my son and daughter, Mac and Kennedy.
I make this commitment to my Uncle John.
To my husband, Brian Roos.
To Sue Lasley, my wife and biggest supporter.
You have to believe. Believe you are capable. Believe you are fearless. Believe you will power through.
Power through.
I will power through.
My name is Alad Mirka, and this is my commitment card.
This is my commitment card.
This is my commitment card. Where's yours?
Make your commitment to the project. Together, failure is not an option.
And just to let you know how big this is, NBA Cares is fully supporting this. This will actually have a launch at the All-Star NBA game in February of next year, so it will become even more international at that point. Michael J. Fox, Linda Ronstadt, Ryan Reynolds, Katie Couric have all committed to this. So this is a very large project. But again, emphasizing the need for more exercise and more information on exercise when it applies to Parkinson's. So enough of that, back to your guys' questions. So we had over 250 questions. We have 1 hour. We're going to talk really fast. So what we did is we subcategorized all the questions into what we thought were the most important and relevant for non-motor disease. So I apologize to those of you who have asked questions about motor symptoms such as tremor and dyskinesia. We will not be answering them here. I also apologize to those of you who asked questions about motor treatment. We'll not be answering those questions here as well, since we're going to be true to the theme. And with that, our first question. Well, actually, two things. First thing is a lot of folks asked about that actual constipation recipe, the prune whip recipe or the rancho recipe. So what we will do is we'll give that recipe to the PANC and have them post it online. So you guys can all get that, okay? Second thing, LSVT. And so our first question is going to be to Renee. A lot of folks have been asking about what exactly is LSVT? What does that stand for? And how can we find providers in our area that are LSVT trained?
I would recommend, if any of you have interest in learning about the program, that for those of you who are computer savvy, and if you're not, ask your children or grandchildren. And so I would recommend that you go to LSVT Global. And you can go on that website and you will find really a plethora of information related to LSVT. So LSVT, that acronym represents Lee Silverman Voice Treatment. And it's a program that Lee Silverman is someone who has Parkinson's disease, and her family was desperate to try to help improve her ability to communicate and speak once again. So the family invested in asking the speech pathology department at the University of Arizona if they would work on creating a program. And so this is the LSVT, Lee Silverman Voice Treatment, is the result of that research. And the clinicians need to go to a training workshop in order to be able to administer the therapy. It's very intense. 4 times a week for 4 weeks, 16 visit sessions. The theory of that being bombardment. So I am a very strong proponent of it. I've been certified for, I believe, 4 years, and the outcomes that I witness with the patients are really quite remarkable. But I will also tell you it's important for the generalization part of it, in order to also continue to maintain that, is to order the DVD that is a part of the program also. And you can find that information out on the website. You can witness also a pre and post treatment. If you're curious about it, you go to LSVT Global and you can see a pre-treatment and post-treatment.
So Renee, actually, and this is going to be made more for our Kaiser patients in the audience, is that we have relatively few LSVT trained specialists. And obviously our patient population is huge. So many of our therapists, and I don't think this is far off from what some people are doing in the community, do what's called a modified LSVT program, to where it's over an extended period of time, so not as well, it's going to be still 16 visits, but it's not 4 times a week for 4 weeks. It's over about a 4-month time period. So are there differences between people getting LSVT the traditional way versus the modified way?
Well, the research indicates that the gold standard truly is to have that intensive 4 times a week for 4 weeks. Obviously, some people's schedules don't permit that. And as stated, not all speech pathologists are certified. And so there are, in some cases, individually based, where we do make those modifications. I do think in my own clinical experience that the outcome isn't as favorable as the intensive 16 sessions in 4 weeks.
Okay. So next question. There were quite a few questions about supplements and the use of supplements when it comes to Parkinson's disease. So I have a few words to say about supplements before we actually begin. It's not uncommon for somebody to come to my clinic and have a whole host of things that they printed from the internet, that their loved one found, that happened to work in Denmark, and you can find on the internet, and it's in Canada, and it'll work for that one individual. There aren't a lot of evidence-based studies to help support the majority of supplements that are out there. And a lot of anecdotal evidence supports its use, but it's very difficult to generalize that for the whole community. So for me, I don't mind if patients are on supplements. Understand that just because it's a supplement doesn't necessarily ensure its safety. It didn't go through phase 2 trials for the FDA, so therefore there weren't any safety measures about it. Okay, so it sounds like it might be safe because they use the term natural. That doesn't necessarily mean that it is safe. Second thing is that a lot of people are with the hope that the supplement will delay progression. That's a very difficult study to do. So if you think about neuroprotective or disease-modifying type treatments, that means that you actually have to figure out how you change the slope of that decline. And that would hopefully infer that there is a change in the disease, in modifying that trajectory. But we have no good objectifiable metric for that. So you can never really, at least the way it stands right now, you can't really do a study and then have the primary endpoint be it's a disease-modifying agent. So there's a lot of claims out there that certain supplements are disease-modifying. That doesn't mean actually they are or have been vetted out that way. That being said and done, there are quite a few supplements out there that many patients are on or would like to be on. So I'm going to try to address some of them here, and maybe Dr. Hadi can help me with this. So first is coconut oil. And we talked about this last year, actually. So there's this idea and concept that coconut oil, being a medium-chain triglyceride, can sometimes help when it comes to slowing progression of Parkinson's disease. What do you tell your patients, Dr. Hadi, specifically about coconut oil?
Same thing. I have the same statement for pretty much all the supplements. Is some of these supplements make theoretical sense that they may have a role, but due to lack of evidence, as Dr. Khandhar said, I don't recommend them. But if someone's on them and they feel comfortable, they feel safe taking it, that's fine, keep taking it. It's just hard to suggest or recommend an expensive supplement without lack of evidence.
I agree. Now, coconut oil is actually an oil that should not be denatured because it loses its effect. So therefore, a lot of people tend to think that they should cook with that oil and then get it into their diet that way. If you cook with the coconut oil, you lose its effect. So it's better to probably keep it in its natural state, which means you want to probably put it in your salad dressing instead. A lot of people are saying, people in the sort of the complementary medicine world are saying that no more than really 4 tablespoons per day. I'm not quite sure where that came from or how arbitrary that is, but 4 tablespoons, not much, and it's probably a better oil than most. So if you're going to be on coconut oil, it's not a big deal, okay? Now, a lot of people do come to me going, I want to be on this because it's going to help to prevent Parkinson's. Well, if you already have Parkinson's, you can't then prevent it. So just keep things in mind about what they're suggesting that this product may do and what it actually may do. Any other supplements that, like glutathione, for example? We have a lot of our folks who go to complementary type programs to where they get IV glutathione once a month, once a week. Obviously, terribly expensive. Oral glutathione. There's a lot of thought, at least basically in basic science research about its use, but I'm not sure whether that clinically translates. What are your thoughts?
I think glutathione being an antioxidant. So there is, that's what we feel like there is some cellular changes that are taking place, mitochondrial damage or other issues that are going on at the cellular level that these supplements may have a role. CoQ10 was looked at from that point of view, creatinine and glutathione, uric acid. So these are all supplements that have been looked at from that point of view. Does it really translate into clinical changes that we see or clinical improvement in motor symptoms or disease progression? We don't, first of all, have the evidence to support that. And as far as disease progression, it's like Dr. Khandhar already alluded to. It's very very difficult to really determine that, especially when you don't have, the timing. You don't know when to start them and how to see over time how the symptoms change over time.
So you bring up a good point about CoQ10. When I was at UCSF, we were part of a clinical trial looking at 200 versus 400 versus 600 versus 1,200 milligrams of CoQ10 in those people with mild to moderate Parkinson's disease. And really the results were varied. And it was kind of interesting because you would actually get some subjective improvement at, let's say, 400 milligrams, but then not at the 600. And then again at the 1,200, which doesn't make any sense. You would expect there to be some sort of linear response. The higher you go, the better you do. Unfortunately, CoQ10 is not regulated by the FDA, which means that manufacturers can charge whatever they want to charge for it. So in my mind, and also the American Academy of Neurology, as well as the International Movement Disorder Society, do not endorse it. So a lot of people are on it. I don't stop it, just like Dr. Hadi said. But what it does do, I think, is reduce the thickness of your wallet. So, but if it is relatively benign, it is safe. And so if some people are already on it, I don't necessarily stop it, but there isn't enough evidence to support its use in those with PD. That being said, we had quite a few questions about the use of cannabis in Parkinson's disease. This always comes up, okay? So I'm going to go ahead and take the plunge into the deep end and see if we can address this. So cannabis isn't what it used to be, okay? I wasn't around during Woodstock days, but it was more of an herb then. It's less of an herb now. It's a lot more concentrated than it was. And unfortunately, there are there's a wealth of information about its use, but there aren't actually FDA-approved NIH studies that show its use in Parkinson's from a symptomatic standpoint. What we hear anecdotally and through case studies and case series research is that it can certainly help to reduce tremor. It can certainly help to reduce anxiety. You know, since we know it causes the munchies, if those people who start to have some weight loss because of their Parkinson's, it helps to increase the weight. And it helps to relax people so they can sleep better. But anything that you expect to cross the blood-brain barrier is going to have a positive and negative effect. The brain is the most protected organ in the whole body. It has a blood-brain barrier. We are now taking something, whether it be a prescribed medication or a supplement, you are expecting it to cross that blood-brain barrier. Let's not be naive in thinking that it's only going to have a positive effect, okay? So this is what a lot of my patients hear that from me, and I want you to be self-advocates, that if you're going to take something, understand that there are consequences to what you take, okay, whether it be prescribed meds or supplements. And so what we do see with those people who are on chronic marijuana use, they do tend to have some cognitive changes. Most importantly, poor judgment, poor insight, okay, which also can happen with just normal progression of Parkinson's. So I'd like to hear actually from Dr. Egli, has anyone brought this to just typical, what is some of the cognitive issues that patients with Parkinson's tend to experience, and do you know much about marijuana and what its effects may be on cognition?
Unfortunately, I don't have much information. There was a whole extended session on this at the sleep meeting in Seattle in June, and basically research stopped in the 70s. When it got put in along lines with methamphetamine and heroin and everything else, drug companies couldn't patent it. Basically, I can't even find a single study that just tells me what happens to a regular sleep cycle if you smoke marijuana before you go to bed. Something as simple as that. We don't have the information, and so it's frustrating because I get that question in the sleep class all the time. And so when you start extending it to more subtle effects with Parkinson's and things, we just don't have information. I do know that they did find that the people who were really heavy users of marijuana chronic heavy users over time had abysmal sleep. But the problem is if they stopped it, they had disastrous sleep, and it didn't resolve for 5 or 6 months after they stopped using it. And they could not get people off it unless they gave them supplements to sleep, like Ambien and things like that, to even have a prayer of getting them off of it. So we know that really chronic heavy use totally disrupted the sleep cycles. But small use and that kind of thing, no information.
Okay. All right. So we'll actually shift gears a little bit here, and I'm actually going to keep the question on this side. There were quite a few questions about sort of just natural cognitive issues when it comes to Parkinson's disease. We know that Parkinson's can lead to dementia, but what I find more challenging is actually the executive dysfunction. So what is executive dysfunction? How does it affect the individual? And how can the caregiver help to support the patient who has executive dysfunction?
That's a big one. When we talk about executive functions in the brain, we're talking about organizing information, prioritizing information, juggling information, having judgment, reining impulsivity, which has already been brought up today, and a host of those kinds of aspects that people can have problems with. And it's a difficult. I don't have a firm answer, certainly that applies to everybody by any means. I think, as we've talked about with other symptoms, even though things might be part of a natural progression in Parkinson's, or whether it's with speech or physical activity and things of that nature, it doesn't mean they can't be amenable to various kinds of interventions. For example, if a person is operating with operating without judgment. Oh, wow, I want to get that Cadillac. You got no money in the bank, and you're going to go down there to the, car store, and you're going to, spend, $55,000 to get a new car. Or I've always wanted to take a trip to, Sri Lanka and see what that looks like. People will get ideas, and in some cases, people are able to have insight into the fact that they kind of lack insight, if you want to put it that way, or you kind of work with that, or work with their partners or spouses about that kind of thing, and people can can at least learn to be willing to be stopped or held back, and other times it's not. They don't necessarily have that capacity. So, it's a very challenging scenario, and in the end, it starts getting into questions of judgment and power of attorney, and whether people can actually, buy stuff that puts you, out of business as a family, because of impulsivity. But I think with creativity, and probably maybe you'd have something to say about this too, there are things that people do for cognitive rehabilitation in general, which can involve, just like she was saying earlier, sequencing functions and directing functions and using how to use judgment and all that could also be applied. And sometimes you have to be creative about how to challenge people. But I think that's all I can say right now.
I work with some individuals with cognitive rehabilitation, depending upon the patient, and the referral needs to come from the neurologist to determine if he feels that it's an appropriate course. And what I've been working on more recently is really helping with one of the components of executive function involves also working memory, that the ability for newly learned information. It's also often called short-term memory. And so one of the things I find some great success with is these folks that are willing to try some of the to-do lists. And one patient recently that I've been working with who has Parkinson's, and his memory issues are really of concern to him, is we've been working on training him to use his iPhone so that he can take pictures of information, and the iPhone with the pictures actually will record the dates. We've also been working with him trying to use his iPhone to use the calculator because he's having difficulty with another executive function, calculations, math calculations. So he's using that iPhone to use the calculator to calculate, for instance, tips when he's going out to the restaurant. I think there are many, many ways that these iPhones can really help with memory. Now, for those folks who are not technologically savvy or have no interest in that, I have respect for that as well. For those individuals, we work on traditional to-do lists where you actually write down a list of items that you're hoping to accomplish in a day and then check off those items that have been accomplished. There are a lot of different strategies that we can try to employ. Sometimes they're successful and sometimes they're not, but they often require buy-in and assistance from the care partner.
I'll tag on to that too. Like, the executive is kind of like, it's not that you don't think to think, and so whether it's writing things down on schedule, I'm a big advocate of for when people are struggling with certain things or schedules or dementia issues, a great big whiteboard, very prominent. Just like if you're going to take a medication, you want it prominent. You want it in things in your face that you need to handle, because you can't trust your mind to remember or to track what you need to be thinking about. That needs to be put in front of you somehow as part of handling this too. So.
When I think of executive dysfunction, I think about what an executive needs to do for a large organization. Okay, so think Steve Jobs, think Larry Ellison, think Bill Gates. They have to be able to multitask, sequence tasks, organize their thoughts. Their processing speed is fairly high. They're thinking a mile a minute. And these are the things, unfortunately, get lost. How does that translate to somebody who has some mild Parkinson symptoms that, unfortunately, has some of these cognitive issues that go along with it? That's why I find that a speech therapy referral early on to kind of help them understand what their cognitive issues are, translate that to their day-to-day life, and then what tools can they use, non-pharmacological, that might help them to achieve that. What I find is if we make the referral too late, okay, and patients start developing having difficulty with what's called functional adaptability, it makes it really difficult for them to learn something new. The area in the brain that actually is sort of the seat of the basal ganglia, Dr. Thacker talked about this earlier today, the seat of where Parkinson starts from, isn't just involved in motor function. It's also involved in motor planning and thinking. Okay, so adaptability is part of that. So as the disease progresses, we start seeing more problems with functional adaptability. And where I see that most challenging is when I make a referral to a physical therapist, and they start giving ideas and things that they can do, learn a new way to do exercises or ways to get up, and yet you have to end up reminding the person again and again and again because, again, they lack that functional adaptability. So how do you approach that, Erin, Christine? At least with the patients that I make referrals.
So I think one of our biggest assets, if you will, is kind of using some of the ideas that have been talked about. For instance, Christine and I might put a note on someone's walker that might remind them to take a big step or scoot forward in the chair. We may highlight one or maybe one or two ideas to try to really get people to focus on, because we have heard having a lot of decisions or thoughts thrown at a patient with Parkinson's might be really difficult. So in physical therapy, we're really trying to simplify things and break it down, and certainly involve the co-patient in carrying through with that so that they know a key word, so they don't feel like a nag if they're saying the same thing over and over and over. Make it a word that may not be even related, but the two of you know what that means.
Okay. There was a nice question, actually, is the reason why exercise is a therapy because it produces dopamine? So the more exercise you do, the more dopamine you create.
The more exercise you do, you can actually make the dopamine receptors more sensitive. So the dopamine receptors that are there can absorb whatever dopamine is there or your medication more easily.
That's actually a very good answer. So it was interesting. I was the chairman of neurology at Stanford is a dementia specialist. And he's always looking at ways in which he can try to help patients prevent sort of the future complications of dementia. And he looked back on all the supplements that have ever been looked at. He did meta-analyses of all the research on all the supplements that have ever been looked at when it comes to dementia management. Okay? And it didn't come anywhere close to what exercise can do in the dementia population. And how did they know that? Okay? They basically looked at volumetric studies of MRI of the brain, to show in dementia that there's volume loss. There's basically atrophy, shrinkage of the brain, particularly in areas like the hippocampus, area that's very much involved in memory consolidation and memory retrieval. After aggressive therapy, do you guys know how much volume was sort of regrown, I guess, if you will, in those areas? 40%. 40%. No medication has ever come close to that. Now imagine if it can do that for someone with dementia, what it can do for someone with a motor disorder like Parkinson's disease.
There are the studies of brain-derived neurotrophic factor in exercise that are being done at Stanford in the Palo Alto VA Center, where the moderate aerobic exercise has been shown to stimulate the release of this brain-derived neurotrophic factor, which actually directly enhances neuron health and even perhaps stimulates neurogenesis, some new neuron growth. So that research is going on right now, but I was at a conference where they were just discussing this right now.
Right. So I think we really are just tapping the surface when it comes to benefits of things like exercise. And now that we're still on the exercise trip here, two questions came up quite often. What's the utility of dance therapy when it comes to exercise, and what about boxing when it comes to exercise? And hopefully not boxing with your partner, but boxing in general.
So as it pertains to dancing, if we think in our minds, something we heard earlier from Renee was about music and the healing benefits of music, right? So often when we think about dancing, we're using music. And when we talk about physical therapy and the benefit for motor symptoms, we often talk about large movements, large amplitude. So you can imagine a dance step or even a simple box step, a large step forward, a large step to the side, back, and again to the side. So we're incorporating large movements as well as music, which I think many of us in the room can definitely relate to music and get some enjoyment out of, which I wanted to say a dopamine thing about enjoyment too. So if you particularly like dancing or a particular type of music, by doing or listening to something enjoyable, you're going to have some improved dopamine availability as well. And in terms of dancing, Argentine tango, interestingly, is the number one type of dance for patients with Parkinson's. But again, if you think about that, it has to do, again, with these large amplitude movements, quick feet. So we'll spend a lot of time doing that in physical therapy.
So can you actually talk a little bit about the Mark Morris Dance Group or no-touch boxing that was actually featured in the San Francisco Chronicle just last year?
So I'm going to let Christine do the boxing piece, but in terms of the Mark Morris Dance Troupe, this is a group that has become quite internationally known, actually, of large groups of people getting together and dancing. And these are dance experts, people that have been in the dance field for many, many years. So I know we have a group that meets at one of the Escatons locally to dance, and there's also a group that's in South Sacramento that gets together and dances at an Escaton as well.
I think there's also one in Davis as well.
Oh, yeah.
Yeah, there's the Davis group too. So I think there's 3 in the Sacramento Valley. And then boxing?
Boxing is actually one of my favorite activities. So those of you who've come to my class know we do a lot of this. You definitely get the high amplitude, so the big movements. It's excellent for trunk rotation. So we know with Parkinson's, it's very typical to have a very stiff trunk. And so the issue with that with walking is that you can fall really easily because you are so stiff. So with boxing, we're really working on getting that whole trunk movement going in all directions. And then also we're working on high intensity, so we're getting you going quickly because that's more beneficial for the brain. And we're working on balance, flexibility, so it's actually a wonderful exercise for you. And then also going back to executive function, you are working on coordination and sequencing and those things as well.
And just to add on the dancing, that's something I'll suggest to our patients who have more of a balance issue. Because usually dancing is with a partner, so it gives you a little bit more stability when you're doing that. So typically people who have more balance issue, that's what I would suggest to them is dancing.
Okay, all right.
I would just say that for the dance classes, if you go online to Dance with PD, you will find the availability of classes in potentially in your region. I know we have 3 here in this region, but there may be some elsewhere. Right. So go online and look, Dance with PD.
There was also a recent PBS special actually on dance, particularly for Parkinson's too, and that was actually looking at Dave Leventhal's group from New York. So there's a lot of questions about excessive sweating, night sweats with Parkinson's disease. So Dr. Hadi, what do you tell your patients who have sweating? Why do they have it? What can be done about it?
So sweating, first of all, we try to determine what is causing sweating. We can have sweating from a variety of reasons that we know of. I mean, one could be if you're wearing off, if the medicines are wearing off, or sometimes if you're dyskinetic. I mean, both those situations. Sometimes we see sweating in general with Parkinson's anyway. So basically what we try to see is first determine the etiology and then address it accordingly. Wearing off is an issue, then obviously you need a little bit medication adjustment. On the contrary, if it's related to being too high or too much on or dyskinetic, then basically medication adjustment sometimes helps with this kind of situation.
Yeah, so I actually would have to emphasize that too. I think that sweating in Parkinson's, part of it's going to be because of your motor symptoms, whether it be off or on. But sweating actually is a normal response, a normal autonomic response that our body does. And unfortunately, a lot of people with Parkinson's have dysautonomia. Their autonomic nervous system is affected in Parkinson's disease. And that's why people are more predisposed to having low blood pressure, why people have constipation, why people have this excessive sweating. And the interesting thing is excessive sweating are in particular patterns. So you may get it only in the armpits or in a cape distribution. You may not get it in other areas. So there are autonomic labs that do full autonomic testing. It's really more of an academic exercise, though. In all of Northern California, there is only one autonomic lab, and that's at Stanford. And they've only been in place for a couple of years. So even UCSF, UC Davis, Kaiser, none of us have autonomic labs. And the reason being is because the information they collect is more for academic exercise. It's really not going to change what the outcome of what's going to happen. It's more for them to research what they can do with that information. So I think until we understand a little bit more about how sweating or other autonomic features really, how they're caused by Parkinson's, is it more med-related, is it more motor-related, and then until they come up with therapies for it, I think that we are going to be left with very few autonomic labs across Northern California. That being said, there were quite a few questions on drooling and what can be done for patients who drool. I remember seeing a poster at the last movement disorder meeting in San Diego that showed, as the disease advances, what are the clinical features that tend to lend to more sort of perceived reduction in quality of life. One is postural instability because they're more likely to fall. One is poor posture because they're bent over. And both those two things just visibly, physically sort of pull you out of social circumstances. But the other was drooling. And I think it's something that we often don't talk about when it comes to our clinic visits.
The manner in which I address the drooling is multifactorial. So one of them is to sort of, as we talk about when we're working with swallowing, think about the swallowing as you're swallowing, is throughout the day I'll remind patients, think about swallowing the saliva. Think swallow. So one thing that helps is sometimes if you have a gesture from your care partner to remind you, sometimes you may not feel that you're having the drooling. Sometimes you do. But to have a gesture that helps remind you to swallow. And to also, I think I mentioned this earlier in the presentation, is to really decrease the amount of sugar, because research has shown that that can increase the amount of drooling. And so then to produce more and more of the swallowing exercise, the best way to maintain those muscles for swallowing at their highest level is to swallow. And that includes swallowing your saliva. Often I'll tell my patients, before you start to talk, if you have an issue with drooling, please swallow first, then speak.
Do you ever recommend to your... Sorry. Do you ever recommend to your patients to suck on sugar-free hard candy?
I do. Yes, I think that's a great recommendation too. Remember, though, sugar-free, not those wonderful sea suckers that taste so good. Sorry.
And what about the use of botulinum toxin or Botox for drooling, Dr. Hadi?
Yeah, it's actually, first of all, we start with simple things like candy, sugar-free candy. Improving posture sometimes helps, more alertness helps with that. But if nothing works and it really is embarrassing or bothersome, then we try to inject some botulinum toxin in the salivary glands here. It's a very simple procedure, and usually that can work anywhere from 3, 4, 5 months, depending on the response that they get. People are getting, and it works reasonably well. So it's a very safe injection, very safe procedure, and it's time tested. So I think that's a pretty reasonable approach. We use it a lot in practice. Yeah.
Okay. Now we talked a little bit about sugar over here. There were quite a few questions on nutrition and Parkinson's. And I think that it's a difficult question to answer because it's very hard to do prospective nutrition trials. Because what are you going to tell patients? We all know that that McDonald's diet isn't necessarily the best diet in the world. And we all know that maybe a Mediterranean diet, might be one of the better diets in the world. So are we going to go, no one's ever going to do a study where they go, okay, well, this half of the group is going to eat McDonald's for the next 2 years, and this half of the group is going to have a Mediterranean diet for the next 2 years, because it would be completely unethical. But there's some research that shows that certain diets, certain portions of what you eat, what you should avoid, are things that we probably don't often tell our patients. So I'm actually going to start with you, Erin. I know that this is something that is sort of dear to you about diet and Parkinson's. So what do you tell your patients? I know they're coming to you for therapy, but...
Okay. So I had the pleasure of listening to someone speak with the Brian Grant Foundation, actually, who is an expert in nutrition for patients with Parkinson's disease. And it was very enlightening, if you will, to hear what she had to say. And I share a fair amount of that with patients if they're interested. It is, of course, under our practice guidelines, so we are able to do that. But one of the considerations was the limitation or avoidance of dairy. And the thought process was that many people have difficulty with digesting dairy to begin with. So for our patients with Parkinson's, let's try to eliminate something that we know is or can be fairly troublesome in the average population. So a minimal amount of dairy was about 4 ounces a day, which is essentially the size of the palm of your hand. There was also some discussion about gluten and whether or not gluten should be included or excluded from the diet for a patient with Parkinson's. And again, these are very hot topics, and I'm sure that many of the experts up here could have heard differing opinions as well. So I think there'll be more to come on this. Generally for patients, we have the caffeine discussion usually, and if people are interested, we do encourage them to increase the antioxidant consumption, whether that's through fruits and vegetables, supplements, if they're already taking them as well.
I was always told that the more colorful the fruit, the more antioxidants. Is that true?
The more colorful. Well, certainly there's the eat your colors idea, right? So absolutely. The darker, very vivid colors tend to be more richer in the antioxidants, yeah.
And what is the panel's thought on the dirty dozen? So things that are not necessarily, the things that you should probably eat organic. Does anyone have any thoughts on the dirty dozen? And by the way, you all can just Google search what dirty dozen is. There are 12 fruits and vegetables that we probably should avoid because the skins of those fruits and vegetables are so thin, and given the fact that most of our agriculture in this country is now a monoculture agriculture, which basically means that there's a lot of pesticide use in those farms, that it penetrates that skin very deeply. Even now, we have seeds for specific products, for specific crop that have pesticide in the seed, which means it's going to be in the product, in the crop. So, and again, the thinner that the thinner the skin of that, the more likely it's going to be holding that pesticide in it. And by the way, there are multiple studies showing that high pesticide, herbicide exposure leads to more increased incidence of Parkinson's.
I will address from a perspective of swallowing related to skins that many of my patients will tell me that they have more difficulty swallowing the thicker skinned fruits or vegetables. And so what they end up doing then often is peeling the skin. So I just want to address, just because I did get a question about the swallowing someone, if that is, may I?
Sure.
Okay. So I was asked to address the issue of their loved one taking large pills and having difficulty swallowing those. This is really a time when I recommend that the patients that come to me that have difficulty with swallowing, not uncommon for large pills to be one of the most difficult things to swallow. I recommend that you go to your pharmacist and or your physician and ask if any of those medications that you might be having more difficulty swallowing in pill form, if they can be provided in liquid form. You have to be careful with your medications in that many of them are time released, and so you don't want to just go about in your own creative way of maybe slicing pills or cutting pills and then taking them. So I suggest that you talk with your pharmacist. But what some people do have is that the advantage of taking their pills that are more difficult in applesauce. So taking the pills with a pureed texture can sometimes help your ability to swallow that more effectively.
Okay. So going back to like nutrition, any nutritional advice that you give your patients?
I typically recommend they seek counsel with the nutritionist.
Okay. And Dr. Hadi?
In general, I suggest that people, not just from a diet point of view, but overall, as the body slows down, it's essential that the weight is lean and you don't gain weight, because you don't want to tip the balance there. So, from that point of view, you have to have a balanced diet: vegetables, fruits, cereal, legumes. These are all known to be helpful. They contain antioxidants and just gives you all the vitamins and nutrients that the body needs. Other than that, I think supplements like caffeine, which is now being supported and looked at from a motor control point of view and from a wakefulness point of view. So all those, that kind of supplement would be reasonable. But yeah, in general, just a balanced kind of diet, low in meat and stuff.
So I just want to make one point about protein. A lot of my patients have a hard time. I'm sorry?
Supplement name?
What was the supplement name that you mentioned?
Caffeine or just antioxidants.
Caffeine or antioxidants? Yeah.
Flavonoids, yeah.
So a lot of my patients have difficulty kind of manage when they should take their meds with protein. So they often take out the protein from their diet so their meds are better absorbed. The problem there actually ends up being that they don't eat much protein during the waking day. You need a little bit of protein during the day because it's what gives you energy in that mid-afternoon when you have that motor lull. So for me, if that means that you have to rearrange when you take your meds so that you can have a little bit of protein, at least early afternoon, midday, it just allows you to be a little less excessively sleepy during the day and kind of keeps you going a little bit late afternoon, early evening when a lot of our patients have difficulty. So there were a lot of questions on sexual dysfunction, and I'm going to pose this to Dr. Egli. Okay, is that it unfortunately unravels a lot of tension between, spouse and, and patient and caregiver and whatnot. So how do you approach that in your clinical practice?
Well, I think this is kind of telling because, when I'm talking with people about trying to get, through their DBS protocol or some of these other things, this has only come up on some occasions, and it reminds me that maybe I should more intentionally bring it up more frequently when I'm having people come in. We have so much to talk about, and it's, I'm usually going by what people are bringing to me, but but I've certainly seen it, and I mean, there's a couple things I would say. I mean, sometimes the problems that I have encountered have to do with the impulsivity, and people being sexually acting out inappropriately, or not thinking about it, or in ways that are offensive to their partner, or what have you. And that can be a problem. I've seen that. But when we're talking about disability and sexuality, sadly, just like we're saying here, I'm glad to hear it's been come up in so many questions, because no matter what, there's no substitute for communication in a relationship. And sexuality and sex is one of those touchy areas between couples so often, and no one knows how to talk about it. Well, I shouldn't say no one, but frequently people don't know how to talk about it, and people are all in their heads about where the other person is. If I'll give examples. If a man is having problems with some impotence or some erectile dysfunctions, but he doesn't want to confront them and withdraws sexually, then wife starts to feel he doesn't love or is not attracted to me anymore, and they get this incredible dialogue going on in each one of their heads, which just serves to cause problems between the two people, the two partners together, and that don't get resolved because people don't know how to talk about it, or they worry about hurting someone else's feelings, or they're worrying about facing their own shame or embarrassment. And so, I guess I would say that people should maybe just bring it up as an issue, at a time when you're not upset, preferably, and just back up. And maybe our speaker this afternoon can speak a little bit more about that. I think it'd be wonderful. Because you want to talk about touchy issues when you're not getting burned up or infuriated or too distressed about them, and step back and always have as a foundation what your relationship is all about to begin with. So if you're going to have a conversation about sexuality, I would suggest that you start talking about your feelings for each other and how you feel your feelings are being and how things are going, and maybe explore how things used to be and how you'd like them to be, and and maybe this can be talked about more, but I think it's actually, with disability in general and even aging in general, it's really one of those topics that doesn't get the attention in the context of relationships that it really should.
And that was excellent. I like the idea of just really starting with communication. So, interest of time, we have about 5 more minutes left, and I have about 3 questions to ask that I think will round out the panel. So, first question is really something that kind of struck me. I actually liked this question, but I thought it was just misinformation. And so I'm going to pose this question to Dr. Hadi. Why did it take 45 years for a scientific breakthrough to occur in Parkinson's therapy? And probably talking about some of the new recent advances this past year. I don't look at it that way, but I want to hear what your thoughts are.
If it's recently, then, we know dopamine has been out there for 50 or so years or so, although kind of accidental discovery, but still, it's been there and it was the mainstay of treatment. I think there was a lot of work being done in the interim, and just because everybody thought dopamine was the miracle drug, was taking care of everything else kind of took a back seat. There was some surgical options that were being looked at. It just didn't, got a little sidelines, I think. And then as the dopamine effect started, we started seeing the complications from dopamine, and then we started seeing that, it's not, we need something more than dopamine. That's when the surgical therapy started getting a little bit more favor, and we started seeing surgical options being more available. And I think since then it's just we've been exploring other mechanisms to treat Parkinson's. It's been going on. It's just these discoveries don't happen in one end. So there's always stuff going on. We just don't hear about them until discovery like this takes place. But dopamine, since being such a robust medication, it was taking care of a lot of stuff as far as motor symptoms is concerned, and the non-motor aspect was actually neglected completely until now we hear a lot more about it in the last few years. But before that, all we were doing were treating the motor symptoms.
So I'm actually going to kind of go over a little historical timeline when it comes to breakthroughs in Parkinson's disease. First half of the 19th century is actually when we understood a little bit more about the pathology of Parkinson's. That's when the discovery of Lewy bodies came out. It was in the early 1960s when they realized that dopamine was the neurotransmitter that was most responsible for the symptoms of Parkinson's disease. 1967, levodopa came out and was FDA approved. Mid 1990s is when the dopamine agonists came out, were FDA approved. Mirapex and Recup were actually FDA approved within the same year. Then you're looking at reformulations of Sinemet over the past 10 years. So different formulations of long-acting, Rytari came out this year, and then Duopa came out this year. That's multiple medication-related breakthroughs, okay? Not to mention all the ancillary drugs that we use. Deep brain stimulation, FDA approved in 2002. So it isn't that it took 45 years. It was that things have been ongoing. And as patients, as caregivers, as part of your Parkinson community, it is your responsibility also to keep abreast of what's going on with Parkinson's disease, because nothing happens without you. Okay, so understand that many of these breakthroughs happen because physicians and scientists were eager to try to understand a little bit more. But a lot of stuff happens because patients and caregivers and loved ones are eager to want to understand more. Look, Michael J. Fox is the one who single-handedly has deconstructed the disease. We now are not as fearful of the disease. We have a face to it now, But all this has happened in the past 10, maybe 15 years. So this is actually a very exciting time for our Parkinson patients. So I think there's a lot going on, a lot more to come, but I don't think that we should worry that, 45 years have gone by and not much has happened. Quite a bit has happened. Last question. And this really relates to genetics, and I really wanted to have this question answered, is this an inherited disease, and will my children be susceptible? I'll put that to Dr. Hadi first.
We have, I think I mentioned earlier that there are genetic determinants that we know can put people at higher risk of getting Parkinson's. There are certain genes that have been identified, especially in early onset and later onset as well, sporadic or genetic. So these genes are there. Does it increase the risk of offsprings getting Parkinson's? If the gene is transmitted, then there is a risk of getting Parkinson's. How high is that risk? Well, not everybody gets it. Even in the offspring, not everybody's getting it. So, I think in the number I'm not sure about, but it's not that high. It's like less than 30%, I believe, if I'm correct. So, there is that risk there. But do we need to test for that gene? Unless it really doesn't change our management, because the people are managed the same way. And unless we have a disease-modifying therapy, unless we have a cure or something of that sort, then really checking for all these genes that we know of really doesn't alter the treatment course.
So I'm going to add to that a little bit, is that I think that the pathology behind Parkinson's, the biological processes that cause Parkinson's ultimately, isn't because of any one cause. If it's entirely genetic, then we would see this completely isolated among specific families, right? It wouldn't actually leave those families if it's entirely genetic. So it cannot, by definition, be entirely genetic unless you guys are all related to each other somehow. If it was entirely environmental, we would see specific populations in specific areas entirely affected by the disease, right? Which is not the case. We may see slightly higher incidences maybe in the Central Valley simply because of the agricultural population there, but it isn't like 90% of the Central Valley has Parkinson's disease. When we're talking about a slight increase, it is a slight increase. And it sort of, raises our radar to the fact that maybe there are certain environmental influences to Parkinson's. So my belief is that there may be a genetic predisposition. Even if you have the gene, the penetrance of that gene is unknown. We don't know how well you're going to express it or not express it. If you do express it, you probably still need an environmental trigger to unlock it. Okay, and I don't think we have enough information to know which of these factors in what sequence led to their Parkinson's disease. So simply just getting genetic testing doesn't really give me much information at all. Plus, even if you have a known genetic marker for Parkinson's disease, the treatment is no different. So it doesn't change what we're going to do from the movement disorder world. Now, where this information is important is in the research arena, because I think that there are specific symptoms that predate the motor symptoms, like constipation, like anxiety, like that REM sleep behavior disorder, like anosmia, which is the difficulty with the sense of smell. Those four things in someone who has not yet developed tremor or stiffness. And then looking at genetics may give us some insight on trying to be able to make the diagnosis earlier. So then we can actually use some of these supplements and thwart the further progression of this disease. But we're not there yet. We're getting there, but we're not there yet. So I think that was a good question to ask about the genetics, but understand that I think we're still in our infancy stages when it comes to understanding sort of the processes that lead to Parkinson's. So that being said and done, I want to first apologize to those of you whom we couldn't get around to answering your questions, but we did get to answer quite a few questions. Certainly being true to the theme of non-motor symptoms. I certainly want to thank you for your attention. Thank you for your questions. Absolutely want to thank the Parkinson Association for inviting us all to speak here today, as well as thanking our wonderful faculty up here who I thought did a wonderful job in giving you their information and how they treat Parkinson's disease. Hopefully it gave you a sense and idea that this isn't an easy thing. This is something that requires multifactorial sort of treatment. So thank you.